This is the central Indian state of Chhattisgarh where I practice. First of all, I must thank the organizing committee of the IRACON 2025 for giving me this opportunity to present my best case. When I got this invite, the first thing that came to my mind was that I should present a rare case, but then I decided in favor of a clinically relevant case. So I'll be telling you a story about a demon who was hiding behind the devil. The story spans over 3 decades, with this patient coming to me in 2005, the year Dhoni scored his first international century. And here was this young lady in my office narrating her story how she was being tormented by this devil. She was having inflammatory polyarthritis, weakness, and high grade fever on and off for last 7 years. Her mother also had similar history, and she probably died of sepsis. This patient was pacifying this devil with steroids and sets, but for last 3 years she has noticed that she was having some deformity in her hands. This is how she looked at that time. This is a much recent photograph, but believe me, except for the sindoor and mangalsutra and few extra kgs, she looked almost the same 20 years back also. You can very well notice the moon faces and the micrognathia. She walked in with antalgic gait. She was pale and had splenomegaly. Her hand joints were swollen and deformed, and hip joints were also, movement was also restricted. Her lab investigation was unremarkable except for moderate anemia and raised inflammatory markers. Although she doesn't have the x-ray of her hands which was taken in 2005, but what I can gather from the old treatment records, she had an erosive polyarthritis of hand joints at that time. She does have an x-ray of hip SAVE which shows a grade 2, that is stage 2 avian of both the hip joints. With this much of information, a diagnosis of systemic onset GIA evolving into adult still disease was made with avascular necrosis, steroid induced, and moderate anemia because of chronic disease and iron deficiency. She was treated with disease modifying drugs and her steroid was tapered off over 6 months. She was given all the supportive care and she was on irregular follow-up for next few years. And the next major event happened in 2010, the year Dhoni lifted his first IPL trophy. This patient was admitted in a nursing home under my care because of polyarticular flare-up involving her hand joints and knees. She was also having fever and she was feeling weak. It was found that she was not taking the methotrexate and the hydroxychloroquine for last 6 months and she was on some loose Ayurvedic medicines. Her family support was very poor. She was socially withdrawn and depressed. Her head joints deformities were more pronounced and there was massive effusion both the knees with flexion deformity of 30 degree. Investigations showed severe anemia, raised inflammatory markers and plenty of pustules in her urine. So we thought that this is a flare-up of her systemic onset GIA because of urinary tract infection and because of the fact that she is off disease modifying drugs. She was started again on disease modifying drugs. Before that, blood transfusion was done, infection was treated, knee joints were aspirated and steroids injected, and all the relevant supportive care was given. Then she was lost to follow up after 2 visits, during which she was improving. The next major event happened in 2016, the year which was not very good for Dhoni, but here was this lady planning for good times. She has been doing relatively well for all these 5 years on self-medication with hydroxychloroquine and some home exercise. But she was still pale despite of her disease being in remission for last 5 years. She was still pale and there was splenomegaly. There were no synovitis, hand deformities were still there, and flexion deformity of knees were much less. Despite of her disease, GIA being in remission, she was having moderate anemia. So this time we searched for another cause of her anemia and we found that She is a patient of sickle cell trait with her hemoglobin S of 33%. Then we did some literature search and we found that autoimmune diseases are more common in sickle cell disease patient and sickle cell trait as well, especially SLE, MCTD, antiphospholipid syndromes. Sickle cell disease as such can affect the musculoskeletal system on its own in the form of dactylitis, chronic synovitis, gout, osteomyelitis, osteonecrosis, septic arthritis. And these patients have increased incidence of MCTD, rheumatoid arthritis, and other autoimmune rheumatic diseases. Coming back to the patient, an X-ray of her hip was taken because she was planning to get married and to have children in the near future. Here we can see that both her knee joint, hip joint damage has increased and she is having Fichet stage 4 AVN or Steinberg stage 6 AVN. This time for academic interest, we did her X-ray hand, which shows extensive damage to her carpal joints, MCP and IP joints. With this much of information, the diagnosis was revised from systemic onset JIA to a seronegative polyarticular JIA, evolving into seronegative RA because her diagnosis of systemic onset JIA was made on 3 points: that she was having fever, she was having polyarthritis, and she was having splenomegaly. Now we thought that her splenomegaly is because of her sickle cell trait, and that's why we revised the diagnosis. And to this JIA, we added diagnosis of sickle cell arthropathy as well. And her AVN was also because of, not just because of steroid, but also because of sickling. Now here this patient, 31-year-old, who is planning to conceive early, with thought of starting hydroxyurea for her sickle cell trait because of her moderately persisting anemia, but decided against because of her planned pregnancy. She was continued on hydroxychloroquine. Folic acid supplements were also given. She was planning for THR, but then it was decided against. Gynecologists were also looped in, and pros and cons were explained to the patient and to the gynecologist. The next year, as Dhoni relinquished the captaincy of Indian team, this patient was blessed with a baby boy. Then she was cursed with this postpartum flare of her GIA. Hydroxychloroquine was continued, and this time we started hydroxyurea in 500 mg OD and then gradually increased to 1000 mg OD. For next 8 years, she has been doing very well with her disease in good remission and her hemoglobin being around 10 to 11. But then surprises do happen. But as in case of Dhoni, flying drone is not a surprise. Similarly, for a patient of JIA and sickle cell arthropathy, infections are not a surprise. This week only, she came to me because of boils in her left buttock, which she was treating with some antibiotic. It was found that she was having leukopenia with her neutrophils around 1800. And for academic interest, we did hemoglobin electrophoresis and we found that her hemoglobin S proportion has reduced from 33 to 14%. Her hemoglobin F, which was initially 1.8%, has improved to 21%. So she was responding to hydroxyurea, but then she had this infection. And because her mother died because of some sepsis, so we didn't want to take any chance, so we stopped hydroxyurea with plan to restart after few weeks of controlling her infection. And this week only, she got her incision and drainage done under care of a gynecologist. So take home message from my side is that sickle cell arthropathy is not just a differential diagnosis of autoimmune rheumatic diseases. Sickle cell process can itself contribute to autoimmunity, and most moon phases of steroid can mask the hemolytic phases. And even should not always be attributed to steroid only. And the lower dose of hydroxyurea should be seen as a disease modifying drug for sickle cell patients and probably for RA as well. And the lower dose of hydroxyurea in recent literature has been shown to be safe during lactation. Thank you.